Muncie. He's an IU graduate, father of 4 children, and he makes his home in Yorktown. So I'm going to turn this over to you, Doctor.
Thank you very much. They've asked me in this presentation to discuss the subject, what is arthritis? I'm sure most of you already have some idea of what arthritis is, and I'm sure that in some instances probably is incorrect. It's rather ambitious, I think, for any group to pretend to be able to decide the question of what is arthritis, because the most advanced medical researchers really don't know the exact cause of most cases of arthritis. It's in its infancy as far as making real strides in its cure. But if you're to be able to recognize quackery in arthritis treatment, then you must have some knowledge of available ethical treatment. And if you are to judge such things, you certainly need some understanding of the basic characteristics of the various conditions that go under the name of arthritis. Therefore, we'll discuss the subject, what is arthritis, based on what the average general public uses their definition. As I put on the board, the word comes from its two components, arthro, joint, and itis, meaning inflammation, and yet most arthritis is not a joint inflammation. So, I'll repeat, we won't go along with the scientific definition. Now, to begin with, there are 2 major classifications of arthritis, which you need to remember. Many others, but they're side issues that will only serve to cloud up your understanding of it. And you can remember simply that there is one group of arthritis conditions which are diseases. And representing this, the outstanding member is rheumatoid arthritis. There are many relatives of rheumatoid, many similar conditions and diseases. But remember, it is rheumatoid arthritis. In the same category of diseases, there are infections of joints. Most of the time in this day and age, we have them controlled with antibiotics. They do not form a major part of our problem. There is another one called gout, which is a form of arthritis. Most of you have heard of it. And it is increasingly diagnosed in this day. The second group are the degenerative arthritis. This is simply another way of saying wear and tear. The joint is worn out. It's mileage, use. Everybody gets it to some degree. It's a combination of normal weight bearing on your joint for so many hundreds of thousands of times, for example, in a knee or an ankle joint, combined with the occasional minor injury, sprain, strain, fracture. All of these things combine to produce what is the most common form of what's known as arthritis, the degenerative arthritis of the joint. Now, some of the characteristics of these 2 major groups, that is the disease type represented by rheumatoid arthritis and the degenerative type, should be discussed. In the rheumatoid arthritis, it's peculiar in that it will attack either your joint exclusive of the spine or will attack the spine and exclude the joint. These various representatives of the rheumatoid disease have special names and eponyms which won't help us at all in today's discussion, so just recall it in that way. It is truly an inflammation. This is a real arthritis. Rheumatoid arthritis is an inflammation. It begins in the soft tissues of the joint, and I've tried to make a schematic drawing to show a typical joint. This could probably be best applied to a knee joint if you leave out the kneecap. But the 2 bones in the joint are abutting here. They're padded on their ends by cartilage, which is sometimes a quarter-inch thick with a nice padding, which young people have, which wears out as you get older. And then surrounding the joint and encapsulating it is the synovium, or the joint lining. Then out here I just drew the muscle or the tendons. These are not part of today's discussion significantly. Now, in rheumatoid arthritis, there becomes an inflammation of the synovium or joint lining occurs. This is where we don't know the cause. Nobody knows why. The joint lining becomes inflamed, swells, thickens, and invades the joint. It can then go on to actual destruction of the cartilage and destruction of the bone Severe deformity formation in the joint. It's characterized early by its pain and aching and swelling of the joint, often redness and heat in the joint. This is the dreaded arthritis that if a patient's in a doctor's office and the doctor says you have arthritis, they immediately think of the deformed, severely crippled rheumatoid patient. As I said, late in the disease, these deformities will happen. In almost every case of rheumatoid arthritis, it has a significant involvement. It can happen at any age, by the way. Children can get it. Elderly people can get it. It is most commonly a disease of young adults and progressing as they get older. Now, the treatment in this disease, rheumatoid arthritis, is a general treatment. This is where the patient needs the help of either a general practitioner or an internal medicine specialist who will treat the whole patient. He's not just a patient with a sick joint that might be in my office on a referral for an opinion, but he needs complete care. His general health is important. He has to be educated to his disease. He has to restrict his activities and adjust to the disease. He has to be treated to prevent deformities. This can often be done simply by some simple exercises or sometimes by bracing. There are many medicines available in rheumatoid arthritis, but unfortunately the ballyhooed cure of the late 1940s in the form of cortisone has not turned out to be the cure. It's been a great help, and it slows down the progress of the disease in many people, helps prevent deformities in many people, but it is not a cure. One of the most important drugs for any arthritis, and it holds true here in rheumatoid, is aspirin. It has an ability to help relax muscles as well as to relieve pain. We have a lot of new drugs in the last 4 or 5 years called anti-inflammatory drugs, and these are very helpful. Many of them are toxic and cannot be used for long periods of time, but are real helpful. You may have also heard of the injection of gold into people with rheumatoid arthritis. This is still being done. It's an ancient treatment, and it, in some patients, does a lot of good even today. And then finally, the anti-malarial drugs were discovered by chance to be helpful in the treatment of rheumatoid. In spite of all the treatments and how much good can be done by it, rheumatoid arthritis very often progresses. Let me say just briefly a word about gout, by the way. Your discussion of arthritis is not complete without it. You must surely have heard of Henry VIII's sore toe and the typical wealthy, obese elderly man with the toe wrapped up in cloth. The subject of some famous pictures, paintings actually. In the past 15 years, even a shorter time, it's become known that this gout isn't restricted to the great toe. It afflicts any joint and any age, any sex, and I've rarely seen it in an obese, hard-drinking, overeating male. So, to wipe out one misconception there, a specific diagnosis in gout is possible. A blood test will prove it or disprove it fairly certainly, and there is an excellent treatment. It can almost always be brought under control. Incidentally, it can attack any joint in any person, and the treatment is almost always quite successful. Now, we'll leave the rheumatoid arthritis, as I just mentioned, and go to the degenerative. This is the one that the average person, if he's fearful of the arthritis as a diagnosis placed upon him by the doctor, he thinks of the rheumatoid. But the average person, on the other hand, who makes his own diagnosis of rheumatiz, he's talking about degenerative arthritis. And this differs from the rheumatoid variety in several ways. Incidentally, it's also called hypertrophic arthritis, which means overgrowth of the bone at the joint. It's also called osteoarthritis. It's a peculiar term, which means bone arthritis. Doesn't make sense at all, but it's even in the medical text. It usually comes on when the person is in early middle age. It's very mild and gradually progresses as long as you live. And it must be obvious that it would, since it comes on as a result of using your joints. It's also obvious that I think that if it's wear and tear that brings upon this condition, then the weight-bearing joints are the ones which will most commonly be noticeable. Many joints can be affected with this disease, but it's not nearly so widespread as rheumatoid arthritis is. The knees and hips are the most common place, the spine is frequent, and it's very commonly in the fingers. The typical patient with this type of arthritis, the degenerative arthritis, has the bumps on his fingers, I'm sure some of you have seen develop in some people as they begin to get into the later middle age, enlarged knees, stiffness in the knees and hips, frequent backache, and stiffness that occurs after rest and is helped with mild use. You surely have heard some elderly person, and maybe some before they're quite so elderly, sit still for 1 hour in class and then creak and complain for about a half a minute when you start trying to get up and move. This is osteoarthritis. And don't forget that it's a normal thing. Incidentally, the wear and tear process can really make a joint look terrible by x-ray and yet be completely free of symptoms. So there's not always any correlation between the way the joint looks and how the patient feels, and the reverse is true. It can look fairly good in x-rays. A mild arthritis can be quite painful. The treatment of this form of arthritis is quite logical. If it's a result of wear and tear, then you should quit wearing and tearing it. You should slow down. It's very, very simple. You don't need a doctor to tell you that if you slow down on your activity, walk less and ride more, lose some weight, don't carry around any extra baggage that your joints don't have to bear. You can remember it treated as you would a smooth tire. Most of you don't recall the Second World War, but we couldn't get new tires, and if you had a bad tire, you didn't drive on bumps and you didn't drive anywhere you didn't need to, and this is a good rule for a joint that's getting a little worn out. Aspirin is very helpful. Don't ever laugh at aspirin. It's probably one of the most useful drugs in the doctor's armamentarium today, in spite of all the sophisticated ones available. It's rather harmless and can afford a lot of relief and extend the usefulness of a joint. The anti-inflammatory medications, which help rheumatoid arthritis a great deal, will help this disease occasionally when the joint is in an inflamed state. And this will occasionally happen. Extra fluid will be produced in the joint. This can be removed with a needle, and a lot of help rendered. And also, cortisone can be injected into such joints, into the joint itself, getting away from the dangerous side effects of the drug, which happen if you give it orally. And that's true of the rheumatoid as well. I've neglected to mention that earlier. Also, this patient can develop deformity. The deformity is usually nothing but an enlargement of the knees, or stiffness and a failure of the joint to go through its normal excursions. But destruction can take place, and mild deformities, usually in the form of either knock knees or bow legs, will develop in the elderly that have this of a severe nature in their knee joints. Surgical care is also available in both kinds of arthritis. This is within my field. Rheumatoid arthritis, surgery is not quite so commonly used, although it is increasingly used in the past 5 years. We can reconstruct certain kinds of joint deformities and render some joints stiff, actually remove some joints so that the two bones will not be touching any longer, will move, but will be unstable but painless. And also in surgery of either kind of arthritis, joints that are so shot that they can't be reconstructed can be made surgically fused together so they no longer move and therefore no longer hurt. The pain of an arthritic joint in its late stages comes from movement of the irregular surfaces. Now, I've drawn this one diagram. If you progress, if you notice now the bone, the cartilage, the joint lining or synovium, very simple scheme. What happens in the degenerative joint first, this nice thick padding of cartilage just simply wears thin. It wears thinner, and instead of being this nature, where the weight is borne, it'll get quite thin, and sometimes as it progresses on, the bone will actually be exposed. You know, the same thing will happen in this bone, and you'll have bone rubbing on bone with no padding. The bone isn't made to take that. It'll wear out, and it'll actually sometimes wear clear up into the bone itself. These ends will sometimes flatten off. And in the final stages, in response to this change and the extra degenerative changes that occur, nature then will produce extra bone. This is why it's called hypertrophic arthritis. And I've tried to scheme it here. You see, the edges of the bone will become cauliflower-like, and these then will catch. It's obvious that the cartilage is all gone. Just little teeny flakes of it around, and it will catch on the ligament. This joint lining stays about the same, except it's thickened in response to this. It becomes irritated and actually inflamed in later stages. But the muscles and tendons will catch. They'll ride over these pieces of protruding bone, and you'll have snapping and catching and crunch. You'll actually have it'll sound like a bag of loose bone sometimes, really, in a bad knee or elbow joint. Now that's very simple. I think you can remember that this is a normal joint, a nice thick padding cartilage that wears away to nothing, and the final stage is the response to that. If it wears off a little more on one side than another, then you can see that this bone down here may be off at an angle, and this could produce a knock knee or a bow leg. And this happens in a great many people, often by the time they're in their 70s, if it's going to occur at all. Surgery at this stage sometimes is helpful in removing these excrescences of bone, in removing the kneecap from a knee joint if it's rough, in fusing the knee together, making it solid so it no longer moves and therefore doesn't hurt. Now in the rheumatoid, an entirely different process takes place. Again, you start with the normal. Can you see it all? Are these big enough? You start with the normal cardiac. You progress then to this stage where the first thing that happens, I'll leave the cartilage here, is the joint lining. Joint lining grows in and becomes thickened. It's almost like your own enemy. It becomes thickened and becomes aggressive, grows into the joint, into the cartilage, begins to destroy and dissolve cartilage. Something takes place in the joint fluid that actually dissolves itself. This process goes through the cartilage up into the bone itself, and will destroy the bone immediately beneath the cartilage. Is that clear? Do you understand what I mean by this picture? All right, now this in the early stages may be nothing but swelling around the joint, this thickening of the joint lining. And it'll be warm, swollen, painful, it'll ache, and it'll get stiff and sore. But no deformity develops as a result of that, and if this is in a weight-bearing joint, it hurts so bad it can't be walked on, and it'll be placed in a comfortable position. In the knee, for example, it usually is in flexion. And if it's left this way rather short periods of time, a few weeks, then it sometimes can never be straightened again. I mentioned part of the treatment is prevention of deformities, and simply by advising the patient on moving the leg in spite of pain. So you see that destruction occurs. It begins to go in here, and it destroys the bone and lower end, and it destroys the cartilage usually completely, and there it leaves then a bone of this nature that all the cartilage is gone. The bone itself is melted away and very irregularly. And if you take a moment, if you shorten that joint by this much, all that cartilage plus some bone, you take that much out of the joint, say your finger joint, you cut that much bone out of there, your joint would just be floppy. You wouldn't have any, there'd be no fulcrum on which one bone might move against the other. So dislocation occurs. And the typical rheumatoid hand is the deformed knuckles and wrists, but with a lot of deformity of the fingers actually dislocated at the knuckle joint. Treatment for this, early stages, as I said, there's no cure, but very often the joint can be injected with a needle placed right into the joint and inject in hydrocortisone, or one of the drugs of that nature. It'll often retard the development of the thickened joint lining so that it won't become as aggressive as soon. Cortisone by mouth accomplishes the same thing, but has many side effects and bad effects on other parts of the body if used indiscriminately for long periods. Anti-inflammatory medicines by mouth will cause this synovium to stop in its progress of thickening very often and afford a lot of relief. But nearly always it'll progress to this stage someday. I probably ought to rephrase that. Very often it will be this. And there are people who get to this stage and never get any worse and actually get some better. the active phase does burn out in everybody, and it stops somewhere. If it goes to the extremes, it goes on to dislocations and deformities. It may stop in between where it just burns slow for years, and it's a swollen, sore, limited motion joint. Surgery here again can be done to rearrange the muscle and ligament pattern so that they can again pull. They can sometimes get shortened. We shorten the ligaments and the tendons so they'll work the joint again. Or go in and reset this rough bone so it's two smooth surfaces and try to reconstruct the joint. Sometimes the joint is replaced by surgery. The pathological material is taken out and replaced with metal. And this occasionally is a good operation. Now, I wanted to bring along x-rays illustrating several of the kinds of arthritis, and I have too many would be only confusing, and I'm short an x-ray of the spine. I wanted to show that because it's so striking, and at the last minute couldn't think of the name of the patient that I knew had that. Here's a man. It's a good x-ray because it shows a relatively normal hip joint. Can anybody see that? See the nice, smooth, round joint? This man is about 65 years old, but that's walked around a good many miles, and still you see a space between the socket and the ball. That space is this cartilage. You don't see cartilage in an x-ray, so it shows up as a space. It would be a much greater space in a 20-year-old person or a 10-year-old person. Now compare that to this hip, and you see the space is gone. There is no space. This deformity of this ball. The socket looks good, but the deformity of the ball, you see the bone is whiter, means it's harder, and has poor circulation. That's the result of 65 years of hard work. The man was a farmer, on his feet many hours, and there's no treatment for that. It must be obvious that you can't give him an aspirin and expect it to get well. You get some pain relief. You can see that such a thing as adjusting a spine wouldn't help this. Actually, the injection of medicine into the joint can afford temporary relief. I don't even do that very often because it's so temporary, and it makes the patient dependent then on the doctor injecting it too often. Medicines aren't going to help this thing that's a worn-out flat tire. But in this gentleman's case, he wanted to work several more years, and after the thorough understanding that it might or might not work, he came back and said he wanted this done. We did it, and he has had a good result. You see, it's just for fun. I thought I'd show you what a false hip joint looks like after the real badly deformed head is removed, and the steel ball in its place and fits right in the old socket. And he's walking, but this doesn't cure him. He can walk with a lot less pain. He can do his job. He should use a cane, and he won't. And so again, we haven't cured him, but we've given him a few years. And that's the whole tenor of the treatment of arthritis. You don't cure it. This lady, it's not very, I'm sorry you probably can't see that well, but you can see, if you want to come close later, you can come up and look at the toe joints, her feet. The joints where her toes join her feet are all dislocated, every one. There's rheumatoid foot. And on the bottoms of the feet, because of the metatarsal head projecting downward, there were huge, painful, hard calluses. And this was corrected by taking out those joints, just removing them. And the toes come around straight, and she walks without pain, and all real well. I'll put that back up after we're through. I think you can see this one by x-ray now. And if you're interested in seeing that one, we could look at x-rays all afternoon, and I think I would enjoy it, but it might bore you a little. This man, at 55, I believe, 56, has worn out his knees. Can you see that at all? It shows pretty well. See the hooks and the irregular places. You see how close together the joint is? That should be a half inch apart at least. He has almost no cartilage left. Other views of this knee show that the kneecap is equally bad. It's lost its cartilage and it's very irregular. This is flattened right off square across here as if he were going to develop probably more deformity on that side. And in his case, that would mean a real severe bow leg because this is the outside of the leg. This man was seen with a large swollen joint, typical worn-out arthritic degenerative joint. And for a period of 3 or 4 years, I saw him intermittently withdrawing fluid, injecting medicine, giving him aspirin, and counseling him on what to do with the Nord. It's real difficult to get people to slow down, and even in spite of pain. So this joint was finally completely wrecked, and he is a real happy man now with a totally stiff knee joint made so by surgery. You probably can see that the joint is going together solidly. It's bone graft, and he walks around with a stiff knee, feeling. Imagine that's quite a handicap, but this man is real happy, and this is an operation that never fails. It doesn't hurt. Now, if you want to see this, what you can. It can only be seen up at close range. I'd suggest that you remember then, if you expect to be a judge of whether treatment of arthritis is in the realm of quackery, that you've got to remember the two types of arthritis, very simple. The one that is the disease process, mainly rheumatoid, much to be offered by medical, physical, and surgical therapy, but no real cure. The second type, the degenerative arthritis, which is a worn-out joint. All of us will have it to some degree, usually best treated by reduced activity and reduced weight and the use of aspirin, occasionally aided by surgery. And the second thing I'd like to have you remember is that either kind of arthritis that I've talked about can be a chronic, long drawn-out, depressing, frustrating, slowly advancing thing which leads itself readily to quackery, lends itself to quackery. To some degree, the condition must be accepted, lived with, and adjusted to. And I can add the only thing that I know of significance here is beware the offer of a cure in arthritis. Now, if there are questions on this subject, I'll say one.